Okay, good evening, everyone, and welcome to, let me think, is this the fourth in our pediatric series? My name is James Mackintosh. I am an FY1 at Stoke Mandeville Hospital. I'm the series lead and I've been trying to organize getting all the different wonderful speakers that we've had each week to tell you a bit more about pediatrics. This week, I will be delivering a talk about prescribing in pediatrics. Importantly for this, to do kind of, as well as some research online, I also went down to the pediatric ward, spoke to some of the pediatric pharmacists, and got them to take me through what are the common things that they see as errors regularly from the junior doctors and others, I suppose, probably some more senior doctors with their patients who are, of course, children. So before we launch into it, I've just got to do a quick plug for our sponsor, CPD.me. So this is a website that provides you with hundreds and hundreds of different webinars, a little bit like this one, that you can use to get CPD certificates for your portfolio. So kind of whatever you're interested in, which is £8 a year, you can have access to all of this different content and build a really strong foundation portfolio. So because you're going through Mind the Bleep using this QR code over here, you get 50% off, so it will only be £8 for the entire year. Okay, so now back to the session of pediatric prescribing. So what we're going to cover this evening, the key differences in prescribing for children compared to adults, some common brand name medications, because at least in my experience of kind of working in the children's emergency department, yeah, we don't want this, is that actually a lot of parents will come in and they will tell you what medication their child has been taking or is normally taking, but they will use the brand name more so than I've seen working with adult patients. We'll do some theoretical stuff on fluid prescribing, which is a little bit more mathematical, let's say, than it is with the adults. But we're going to do a couple of examples there. And as always, as you guys always say in your feedback, we're going to be doing some cases just so you can put this stuff in practice or just see how exactly it's going to affect you in your jobs in pediatrics. And I'll also say it's not just if you have a job in pediatrics, actually. If you are on call in surgery or medicine, you may be asked to come down and see someone in the pediatric emergency department, and often you will end up prescribing them some painkillers, particularly if you're part of the orthopedic team or part of the general surgery team. So it is well worth for any F1 or F2 to have some awareness of what differences to take into account with children. Okay, so how is prescribing different in children? This may sound very obvious, but when you go to look up what you're going to be prescribing, so the doses, the indications, you need to use the children's BNF. So if you go onto the regular BNF site, there might be some information that applies to children, but you need to switch it from the BNF to the children's BNF to get the up-to-date, accurate stuff and it to be for medicines that are licensed in children. And one of the next thing is probably that I've got on my list is the weight and age-based dosing. So this is probably one of the biggest differences in children than with adults. So pretty much anything you prescribe in pediatrics is going to be either based on the child's weight or their age. So you need an accurate number for both of those things. And what's really important with the age is if you're prescribing anything at all for someone that is 12 years old or younger, it is a legal requirement in your documentation that you record what age they are. And that is so that a pharmacist or someone else can come along and check that actually that your prescription is right. We also have to consider the route and formulation of the medicines that we're giving. And it has a particularly big impact on the compliance in children. You know, 3-year-old toddler, they're not going to be very good at swallowing tablets. They're going to be very unhappy with you if you try and give them something with a sharp needle, whether that's IV or subcutaneously. So a lot of the time you'll be using for younger children things like oral suspensions. And then when we get those oral suspensions, we also have the slightly strange consideration of how that medicine might taste. And the only real way to kind of find this out is talk to patients, talk to people that work on the pediatric wards. So whether you're seniors or someone that's more experienced, or your pharmacist, and do take into account, if it tastes horrible, particularly again, those toddlers are much less likely to take the medication that you've prescribed if it's hard to get it into them. The reason that we're giving a talk actually on the key differences in pediatric prescribing is how important it is for children, because they have an increased susceptibility to drug reactions, dosing errors, partly because of just they are much smaller, have a faster metabolism, so it's not going to take as much of a wrong dose to give them an overdose. As we've talked about before, with the weight and age-based calculations and the fluids, it's a bit more maths, so it's more likely that someone will make an error. And again, it's not, say your paracetamol for adults, it's 1 gram QDS unless they weigh less than 50 kilos. So that's quite easy to just have in your head, and you see it every day on drug charts, and it's easy to just scribble that straight down. Whereas in children, all the different children will have different ages, different weights, so you're constantly seeing different doses written down, so you can't really get a feel for perhaps what's right and what's wrong just by looking at it. And the last point I've got on my slide is different licensing. So there are some medications that we use in adults that just aren't licensed yet for children. And it is first of all, you cannot then use them in children, but it is a serious, significant issue if you do. So an example might be, for example, in a teenager that's had a DVT or a PE, if they were an adult, so 18 and above, we might use a DOAC or something like a Pixaban. You cannot, and I can't stress this enough, cannot, even if they're 17 and a half or their birthday's in a week, you cannot prescribe that for a 17-year-old. And another thing that I wanted to highlight, because like I said, if you're a surgical F1, you may be asked to come down and get some painkillers prescribed for, the acute abdomen, the appendicitis, things like that. Codeine, quite often not a good idea. So there are many things where actually codeine, you do not prescribe it. So any child under 12 does not get codeine. But if you have a child that's come in for tonsillectomy, obstructive sleep apnea, we also have, if they have breathing difficulties at all, there is strong evidence out there that codeine can make that worse in children. So you cannot prescribe it. It is contraindicated. And for any patient that is known to be a CYPD6 ultra rapid metabolizer, obviously you can't just come out and ask that straight away to a patient, because they will give you a very funny look, particularly if they're a child under 10. But it is just kind of trying from your history to work out, have they had severe drug reactions in the past? Do they require higher doses than other people, or lower doses than other people? And taking a thorough history, looking through the notes, it's very, very important. So just to illustrate some of the, the complications that can occur with prescribing. So this is kind of a case where you've probably had it on the wards if you're working as a junior doctor, whereas one of the nurses will come up to you with a drug chart and they'll say, oh, doctor, this looks a little bit funny. Are you sure I can give this? Because, the nurses, they probably know more than you do. They administer the medication. They see this stuff every day. And they just want your sign off, or realistically, often they're hinting at the fact that it's wrong and you ought to correct it. So if we look at the example I've given here, so we have a child, age 13 months. We have a recent weight. We have 9.5 kilos. We asked the nurse to go and weigh them before prescribing them, so that we know that this is nice and accurate. And in the drug chart, they've been prescribed 95 milligrams of IV paracetamol QDS, which for those that aren't aware means 4 times each day. So I've taken the relevant part from the children's BNF here for paracetamol. So we have a child here, body weight up to 10 kilos, so that's us, and they can have 10 milligrams per kilo every 4 to 6 hours. So 10 milligrams per kilogram. So we would do their weight, 9.5 kilos, times by 10, which is going to give us 95 milligrams. So far, so good. That looks okay. They can have it every 4 to 6 hours. This has been prescribed 4 times a day. So 4 times in 24 hours, that's 6 hourly. So again, that looks okay. It says we want to administer this over 15 minutes because it's an IV prescription, which is cut off above, but you have to trust me here, this is for the IV meds, but the maximum is 30 milligrams per kilo per day. So we know that we've given each of these doses is appropriate on their own, but if we look at 30 milligrams per kilo, so 30 lots of 9.5, that is going to significantly exceed the 95 milligrams QDS. Does that make sense? Because you're essentially doing that times 40. So if we were to give the 95 milligrams 4 times, we would exceed the 30 milligrams and be giving an overdose of paracetamol to that 13-month-old. So this prescription is not okay. It needs to be crossed out, needs to be day text, and a more appropriate prescription needs to be written. And actually, one of the things that one of the pediatric pharmacists recommended to me is when prescribing these things by weight and age, record the weight and the age and kind of that you've done 10 milligrams per kilogram. But it's also really important that you document, even when you've put QDS or every 4 hours, what the maximum dose is per 24 hours, and that just prevents drug errors like this from happening. Okay, so just a little bit of extra advice here, thinking about the different points that we've already talked about. So use written guidance. I definitely found when I started as an F1, I looked up pretty much every prescription I wrote. I checked it in my BNF, and I still do that if it's a drug that I'm not familiar with, or I think, I haven't done it for this particular reason, or I'm just not 100% sure. In children, use the written guidance, whether that's the children's BNF, whether it's your trust guidelines, whatever it is, use the written guidance, sit down, don't do it off the cuff or estimate, work it out, get someone to check it, which I think is point number 3. So check and double check, particularly if you've done a few different calculations. It's really good to get someone else, even if they're the same grade as you, to just have a look at it to make sure we're not making errors. Ask your seniors. I think that's kind of definitely a theme that we've had across all of our pediatrics talks. If you're unsure, ask the doctors that are above you. They're really knowledgeable, really friendly, and they want to help you. They want you to come to them with the issues that you're having. The only time they will get upset, Dr. Armstrong said, the only time she'll be upset with you is if you don't ask for help. Okay, and then our ward pharmacists, the whole reason they are on the wards and they try and be around is so you can ask these questions and get help with this stuff. Because we don't want to be making drug errors for anyone, adults or children, but it's extra important in children because of the likelihood of them having a more significant reaction. I also got a couple of extra bits here. So we've already talked about the legal requirement to include age on prescriptions, but they don't advise, and this is when you tell parents, that they mix oral suspensions with feeds for babies. So I got this from some of the prescribing guidelines on the children's BNF. And this is really important because if you mix in the medication with a feed, they may not finish it. You're not 100% sure exactly the amount that they've had so far. If you take this much milk and this much medicine and they've had half of their feed, and you need to know whether or not you can give them another dose of something else in another way, you don't know how well that's mixed in. You basically just don't know exactly the amount of medicine they've had, when they've had it, if it takes them, a few different feeds to get through it. So that is not a good idea. It's much better to get one of the tiny little syringes and you kind of just squirt it into their mouth. That is generally the best way to do it. Okay, and then we have another case. So this one is kind of getting at the brand name medications, which I mentioned at the start. So we have a 7-year-old girl coming in with some abdominal pain and a fever. And her mother tells you that she hasn't had any paracetamol at home, just a teaspoon of Calpol a couple of hours ago, and she has no allergies. But, the 7-year-old, they're in a lot of pain. They're kind of, they're in a bit of, they're quite distressed. So the mother asks you, can you prescribe something for the pain? And you need to work out how much paracetamol can they have. Now, a lot of parents do know that Calpol contains paracetamol. And for those of you that either didn't have Calpol as a child or didn't grow up in the UK particularly, Calpol is delicious and makes you feel so much better just because it's all strawberry and sweet, and it's also full of paracetamol. So when you get told they haven't had paracetamol, but they've had some Calpol, this is what they are likely to have had. So you need to take into account the amount of paracetamol that is in that Calpol. And just so you know, a teaspoon you can take to be roughly 5 milliliters. but it gets slightly more complicated than just having a look at the picture over on that side of the screen. So there are two different types of Calpol that you can buy here in the UK. So you get Calpol infant suspension, which has 120 milligrams of paracetamol per 5 milligrams. And you get the Calpol 6 Plus suspension, which contains over twice as much paracetamol per 5 milliliters. So it's really important that you go back to that mother, back to that parent, and try and clarify which of the two they've had, because it will affect how much paracetamol they've had and therefore how much you can give. If they don't know, you're unsure, always err on the side of caution and assume that they've had the higher dose already. So when you prescribe further pain relief, you're not going to be giving them too much paracetamol. Another couple ones that I've come across quite regularly in my care background would be Piriton. People generally refer to it as Piriton, which is a hay fever relief kind of liquidy, syrupy, quite sweet thing, but it contains chlorphenamine. So again, if you're prescribing something that perhaps interacts with chlorphenamine, or you want to give them more chlorphenamine, that again needs to be taken into account. And if you do take a drug history from their parents and they're giving you all these brand names, it's really important that you go off and you kind of look these things up, or see if they can find a packet for you. And then with my epilepsy background, Epilim is sodium valproate, Keppra is levetiracetam, which I can never say properly. But again, these are commonly referred to by patient or children and their parents as Epilim and Keppra. But these are the actual medications that you'll need to look up in the children's BNF to check interactions, check dosing. Okay, so if we go back to that case, we have gone back to the mother, we've clarified, and she says, oh yes, we used to use the infant one, but now, we've got the 6 plus one for my daughter's 7. So if we look at the 250 milligrams per 5 mil, so 1 teaspoon will be 250 milligrams. And we go to our children's BNF, look up how much paracetamol they can have orally, which will be 240 to 250 milligrams every 4 to 6 hours. So they've had that 2 hours ago, which means they need to wait at least another 2 hours before they can have a similar dose, whether that's Calpol 6 Plus, a tablet of paracetamol, whatever. But you need to wait, so you'll have to be thinking about some other sort of pain relief. Okay, and then here we have another case. So I am monitoring the chat on the side of the video, so if anyone is able to, just have a think and stick some suggestions in the chat. I've got a second laptop there, and tell me what could go wrong in this scenario. So we have a 15-year-old with suspected acute appendicitis. Once again, it's painful, they're quite unhappy, and the nurse has said, well, do you mind prescribing some analgesia? The patient's already had paracetamol, and could you give them something stronger? The paracetamol hasn't really worked. You are the surgical FY1, and you can see they're well, actually you decide for one reason or another to prescribe 5 milliliters of Oramol. This is about a teaspoon. It seems reasonable. You look at down here, you look at the children's BNF excerpt, and it says, initially for someone of this age, you can give them 5 to 10 milligrams every 4 hours, and then you can adjust it just like in adults to their response. So what's wrong with this prescription here? Because Oramorph, if it's a liquid, you can certainly have 5 milliliters of a liquid. But why might this not be a sensible way to prescribe our oral morphine? I'm just going to give you a minute to have a little think. And the issue, and this again, it's the same in adults, but it seems to happen more in children, at least according to the pharmacist I was speaking to. But when we prescribe things in milliliters as a volume, if the medicine comes in different strengths, which actually Oramorph does, and the ward may, they may finish one strength and move on to a different strength, 5 milliliters of a different strength of Oramorph is going to contain a different amount of medicine. So it's really important that when we prescribe anything, children again or adults, that we do it in mass units. So that's grams, micrograms, milligrams, but ideally we shouldn't ever really be prescribing as a volume, because like I say, a different strength, the same volume will mean a different amount of medicine is given to that young person. Okay. Now we're going to move on to a slightly more theoretical part. You may remember this from medical school. You may be at medical school and be desperately trying to memorize this before finals. But fluid prescribing in children, it is different. They have different requirements. You kind of have to take into account different factors, and there's a few more calculations that go into it. And it's important that you understand how to prescribe fluids in children. Just because of the last point I've got here on the PowerPoint, children have a really large physiological reserve, which is excellent, but because it means actually when they're kind of quite unwell, they can kind of deal with it. They can kind of keep going, and then all of a sudden they can't compensate anymore, and they just deteriorate incredibly rapidly. And so our pediatricians have to work very quickly to resuscitate them, to get the right care to them as quickly as possible. And making sure that their fluid balance is correct, whether that's resuscitation, maintenance, or replacement, is a really big part of this. So let's start with fluid resuscitation. So similar to adults, we use glucose-free crystalloids, which I'm sure most of you will know. Crystalloids are either sodium chloride 0.9% or normal saline. I know many people will say, there's nothing normal about normal saline, but either that or Hartmann's are both crystalloid fluids. And the standard amount that we will use is 20 milliliters per kilo, given basically within 10 minutes. So we give it nice and quickly to try and resuscitate someone. Again, we need a nice accurate weight to work this out. So ideally we would have weighed them before. We may have to go on record in an emergency scenario, or, I don't want to say estimate, but I think sometimes you can have kind of a best guess. Again, be conservative if you have to be. And in adults, when we're prescribing our 500 milliliter bolus of fluid, we have exceptions where we only prescribe half that, 250 at a time, because we want to be more cautious in patients with heart failure, patients that are very elderly. And similarly in children, there are exceptions where we actually halve this and we give 10 mils per kilo. And I've just jotted them down here. So in the neonatal period, if they're in diabetic ketoacidosis, this one is really important. If you give fluids too quickly to a child in DKA, they are a really high risk of cerebral edema, which is a very significant poor outcome, and something that we very much want to avoid. Always in DKA, follow the guidelines, but it is somewhere where that we do need to give a smaller bolus of fluid, just to be aware of that. If they are in septic shock, so not just sepsis, but septic shock, significant trauma, and again, heart failure, cardiac pathology, we might want to go for that smaller bolus of 10 mils per kilo. If you're unsure, err on the side of caution, go for the lower one, 10 mils per kilo rather than 20. And again, run it past your senior. It's very unlikely as a junior you're going to be resuscitating children on your own. But please run it past a senior. You will always be able to find someone that will be able to help you out. In the meantime, go be slightly more cautious. You can always give them, one small bolus and then repeat that again, because it will go through nice and quickly. Okay. So another case. So this time, if you have a little think about what you need to know in this case. So 2-year-old girls come in, she's got fever. They go into the triage room. Nurse does some obs. She has a heart rate of 140, respirator 28, blood pressure 70 over 38, SATs are 98 on room out, and their temperature is 38.1. So you've done an A2E assessment, and you decide to prescribe some fluids. Now, what do we need to know about this girl, about this case, about medicine in general? What do we need to know to address this properly? So the first thing I think I would like to know is probably what the normal values are of vital signs. Because if we had an adult with these OBS, we would be very, very worried about them. Definitely getting a lot of fluid in them very quickly, amongst other things. But in, so I said this girl was, 2 years old? So heart rate, that's actually a normal heart rate for someone that is, around 2 years old. Respirate again, abnormal in an adult, and a 2-year-old, that'll be absolutely normal, but their systolic should be up kind of in that 80 to 95 range. This little girl's systolic was 78, so that is why we're prescribing some fluids. Once again, we need a nice accurate weight. So this little girl weighs 12 kilos, which is kind of an average-ish number for someone of that age, or a girl of that age, I should say. We've checked, they have no past medical history of cardiac pathology. There are no other things on this list that we're particularly worried about. So we do our calculations. We can give us her 20 mils per kilo, so 20 times 12, which is her weight, gives us 240 mils, and we're going to give that over less than 10 minutes. And then, as always, we'll reassess, do another A to E, and see what effect that's had on the systolic blood pressure. And obviously, we'll be escalating to seniors and getting some help if we are worried. Okay. So next part is routine maintenance. So if someone is nil by mouth, if they can't swallow, if they've got poor intake because they're just feeling not very well, we prescribe them some routine maintenance just to keep them going. So in neonates, there are some very specific, each day this is what you would be giving them, the amount, this number of mils per kilo per day, given after, the certain number of days after birth. Look this up, look it up, get someone else to help you with it as well, to make sure you are doing it right, because these are tiny, tiny babies and neonates. So it is important that we get this right. I'm not going to read you all the values. You guys can read it. And again, look it up if you are working with neonates. But for a child, we use something called the Holiday Seeger formula. You will have heard about it at medical school. If you're at medical school, this is something that you are supposed to know for your finals. So we give 100 mils per kilo per day for the first 10 kilos. For the next 10 kilos of weight, we give 50 mils per kilo per day. And then any weight over 20 kilos is 20 mils per kilo per day. Now, that's a lot of words, a lot of numbers. Let's do an example just to illustrate what we mean by the first 10 kilos, the next 10 kilos. Okay. So, 10-year-old girl, nil by mouth pre-surgery. She weighs 33 kilos. So the first 10 kilograms of her weight, because she weighs more than 10 kilos, we will be doing 100 mils per kilo per day. So 100 mils times the 10 kilos gives us 1 liter or 1,000 milliliters. So we can take kind of 10 kilos from her 33. We've accounted for that. So there's still 23 kilos left. So the next 10 kilograms of weight, we're going to give 50 mils per kilo per day. So we do 50 times 10, because we've got another 10 within that range of our 23, which is going to give us 500 mils. And we can take off the next 10 kilos. So if we take off that, we're left with 13 kilos left. So 20 mils per kilo for the weight that is over 20 kilos. Now, for some reason, I've written 12 here when clearly I should have written 13. But let's just go with it. So 13 times the 20 mils would give us 260 mils. So our total daily fluid requirement would be the total of those 3 values. Which again, I seem to have added them up wrong down here. How very embarrassing for me. But anyway, so we would do the 1 liter plus the half a liter plus 260 to give us 1,760 mils of fluid. And if we look here, the fluid that we're going to be using is 0.9% sodium chloride with 5% dextrose, which should also deal with the fact that she's not taking in any calories via her mouth. Now, if we had a different patient that only weighed 3 kilos, let's cover up that 3, so a 3 kilo patient, within the first 10 kilos of weight, we're giving 100 mils per kilo. Now, there are only 3 kilos. That would mean we would be giving just 300 milliliters. Hopefully that makes sense to you. If you do have any questions, any issues, do just stick them in the chat and I will just try and keep an eye on it while I'm talking. But the best way to get better at this sort of stuff is just to practice. Practice, get someone to check it over. But this is something that I would expect, a final year medical student to be able to do, and to kind of have these values in your head for your exams. As an F1, again, just look it up. don't try and remember stuff if you haven't done it for a while. It's not worth it. Just look it up, make sure you do it right. Okay. Okay, and then the last part of the fluid theory that I wanted to go into was replacement fluid. So this is if someone is dehydrated, if they've lost fluids through burns or through, you know, you can sweat it out if they're really febrile, third space losses, etc., etc. So you can assess this clinically, which is very much a skill you kind of have to develop over some time in clinical practice. I would try and do it alongside a senior, get them to say, oh, well, you know, why do you think they need about that much fluid? Why this, why that? Because it is kind of more of an art than a science. But the maths part is the bit that I'm just going to quickly go through with you, is calculating the loss in fluid using the weight when they were well and now. So particularly for younger children, we actually do weigh them quite frequently on their growth charts. They get weighed at school. Parents will quite often have a good idea of how much their child weighs. And actually, if it's someone that you've had in hospital quite frequently, you may know what their weight is when they are well. So you take that as their baseline, and then we use the weight that they are now to work out how much fluid loss there has been. So we take their well weight, we subtract the current weight. So how much weight loss has there been? So if we have a 10 kilogram toddler, I suppose, and they've lost 1 kilo of weight, so we would have their well weight, they currently weigh 9, so that gives us our 1. We then divide that by their well weight and times it by 100 to get that as a percentage. So that toddler that has lost a kilo from their normal 10 kilograms has lost 10% of their body weight. So now if we want to convert that into the fluid deficit, we know that 1 liter of fluid weighs 1 kilogram. So we can take our percentage dehydration. So our example was 10%. We times that by their weight, and then we multiply that by 10 to get how many milliliters of fluid we need. Okay, so in this scenario, it would be 10 times 9 times 10. So that is 900 milliliters. Now, the total fluid requirement is going to be their maintenance fluids plus this fluid deficit. So we would take the fluid that we would do the calculation we did before to work out what they just need daily, and then we want to add in what they've already lost. Okay, I hope that makes sense. I know this was a slightly shorter webinar than some of the other ones. But I just want, before we finish, I just want to highlight some useful resources. So the Children's BNF, we've already mentioned. There is a really good, actually, prescribing in children medicine guidance, which is from NICE, but it's published on the BNF. Well worth a read, and where I got quite a bit of information for this presentation. There is also from NICE a really good IV fluid therapy in children and young people guidance. If you are actually doing this in practice, this is where I would go to look it up, and I think they also have some nice examples there. Similarly, with pediatric IV fluid prescribing from Geeky Medics, again, check it out. They've got kind of practice questions down the bottom. You can have a go at it, you can get confident, and it's good practice either for your exams or your own clinical practice. Pediatric prescribing, there is already an article on Mind the Bleep. If you want to write other articles on pediatrics from Mind the Bleep, do go to our website, and there is a form you can fill out, and it will ping through an email to me that says you requested to write an article about something, and I will get in contact with you. Okay, for the junior doctors, we have script modules. There are some on pediatric prescribing, and similarly using local guidelines, asking our seniors and our ward pharmacists. It's kind of, you know, the same sort of things that we do all the time, but equally important here. Okay, so hopefully that has been informative. Please do take 5 minutes to give us some feedback. Once you've filled out the feedback form, there's a link on the Facebook event. There's this QR code here, and in a second I will pop a link actually in the chat, so you guys will be able to access that there if you hold on a sec. But I do read all the feedback, positive and negative, and we try and take it into account when we're planning subsequent sessions. So if it's not myself leading the session, I do actually take the previous feedback, summarize it, and send it to who's giving our next talk, just so they know what is working well and what you guys are benefiting from. So if I have a look on here, I should be able to get a link and post it to the chat. But we find it really useful, actually. So cool. So I've stuck the feedback. And again, it means you all get a certificate. So if you're a medical student and you just want to show, yes, I have or I have a lot of interest in pediatrics. Look, I've attended all these sessions. That looks really nice in your portfolio. If you're a foundation doctor and you have the foundation portfolio and you need some evidence of your non-core teaching, again, you can submit via Horus your certificate showing, look, I attended this session. It was about an hour long, and you can put it down for your non-core teaching hours. Okay, if you do have any questions, by all means, you can pop them on the Facebook group, or I think there is a way to pop it in on the feedback form. I don't know if there was a free text bit or not, but do by all means let me know if you have any issues with it, if I made any mistakes other than those typos that hopefully I highlighted as we went through. But thank you very much for joining us. So, I'm currently working out how to stop this live stream.